to make you feel my love. When the evening shadows and stars appear, and there's no one there to dry your tears, I could hold you for a million years, make you feel my love. I know you haven't made your mind up yet, but I would never do you wrong. I've known it from the moment that we met. There's no doubt in my mind where you belong. I'd go hungry, I'd go blind for you. I'd go crawling down the avenue. There ain't nothing that I wouldn't do to make you feel my love. Storms are raging on a rolling sea, down the highway of regret. Winds of change are blowing wild and free. Yeah, you ain't seen nothing like me yet. There ain't nothing that I wouldn't do. Go to the ends of the earth for you. Make you happy, make your dreams come true. To make you feel my love.
Ladies and gentlemen, please welcome back to the stage Dr. E. Blair Holliday.
Paul recognized the need to help folks around the world. When we first met Paul almost 2 decades ago, he showed us the path. And when he established Partners in Health, which changed the world globally, he did so with the intention of making sure that we bring care desperately to those who need it, not just locally, but again, across the world. And he did that by recognizing he couldn't do it alone and that patients needed to be able to access diagnostics and care. And it was the ability to access those diagnostics and care that brought PARM to ASCP. The irony behind this conversation is that Dr. Farmer searched out ASCP. He brought me to the table and he showed me the way. And as you saw in that video, it's the only person I've never been able to say no to. When he passed away a couple of years ago, it sent shockwaves through the community. In fact, not only was a close friend and colleague to many of us, he continued to impress all of us through the legacy of his work. And just as you saw yesterday with Martin Luther King III, we saw with Paul. And what we're seeing now is the ability to provide the path, the conduit for global health, to not only pay homage to his life, but to do what he intended for us to do. Paul died at the young age of 62. And today, we have an ambassador to showcase what he taught us. It is my privilege to introduce you, Paul Farmer, lecturer, the scientific keynote the Ambassador to the United States, Dr. John Nkinga-san. Dr. Nkinga-san is a leading virologist. Come up, John. Dr. Nkinga-san is a leading virologist. He's a longtime colleague of ASCP. He continues to serve the country that he loves, hailing actually from the beautiful country of Cameroon, and now he's here with us as the Ambassador to the United States, the Global AIDS Coordinator, the Senior Bureau Official for Global Health Security and Diplomacy. The diplomat oversees the United States PEPFAR program. If you don't know what that is, that's the President's Emergency Act for AIDS Relief. And under his leadership, he's made historic strides, not only in addressing HIV/AIDS, but helping improve the lives and the supply chain and the conduit to patients across the world. And since its inception almost 2 decades ago, $90 billion have been cumulative in helping not only thwart this disease, but bring the appropriate prevention and now research so that the ongoing legacy of this program can continue under his tutelage. So what's important here is his tenure continues. He's also been the African Center for Disease Control Prevention. He started this center many years ago. The CDC appointed him to begin looking at how we can support our colleagues across the world. And we found out that, again, another lateral legacy with ASCP was to be instrumental in the delivery of that program. But from the beginning, in 2003, ASCP has been working hand in hand with this gentleman in over 30 countries to bring sustainable systems, solutions to healthcare across the world. If any of you have ever been on an ASCP trip as an ambassador, for the ambassador, would you please stand up and be recognized? Today's world, global health is local health. And the local health is we're progressively smaller, but our expectation is significantly bigger. We've got to go beyond the nation's borders. We've got to take what the ambassador will help us understand. I want you to think about COVID. Think about what happened during that time. We are making a case that, in fact, bringing national security across the world by helping decrease the disease burden will allow the United States and the world to come closer together, and that, in fact, is what we are, stronger together. Thank you. We're delighted to have you here, Ambassador. Thank you so very much.
Thank you.
Please enjoy.
Thank you. Thank you, Blair, for your very kind words, and truly an honor and very humbling experience to have been asked to deliver Paul Farmer's lecture. Paul, I'm sure you saw in some of the short clip that was played, we had had many interactions. And my last interaction with Paul was in Kigali, where in September of 2021, and we sat, I had been appointed, but not yet confirmed, to serve in this position. And Paul, this was in the middle of COVID, and I was in Kigali to discuss the vaccine access, and in a meeting with President Paul Kagame. He happened to be in Kigali, and we had a late brunch together. We sat at back at the hotel lobby and reflected on what he could possibly do to support me when I took on the job as the PEPFAR coordinator. And you could see deeply in Paul's eyes the individual I've known, you have known. You either know him as a friend, a brother, a colleague, or in whatever capacity. But I'll characterize Paul as one of the greatest icons in global public health, and I've been in this space for 35 years. Paul was a fierce warrior in the fight against global health inequity. And I hope that in delivering my lecture, in the next 28 minutes, I will do justice to that icon. So in preparing this lecture, I wanted to cover three things. Use HIV/AIDS as a segue to describe the global inequities that existed and how Paul interacted and interfaced in that space. But then also look at the critical role of political leadership. What political leadership means for all of us if we have to address the gaps in global health inequities. And lastly, the power of leveraging partnerships. So if you had something urgent to do, and you wanted the three key messages there, those are the three key messages there. So let me start with this. So many years ago, in 1971 in The Lancet, a paper was published by Julian Hart, and essentially said, or stated the law, the inverse care law. The inverse care law stated that resources are always inversely related to where the needs are in public health. Amazing law that he stated at that time. He didn't mention inequities, but I thought that Julian Hart in 1971 was referring to inequities. And we continue to see that or recognize that inequities in global health is a serious threat for global health. This is the fight that Paul fought. As I said earlier, Paul, in my view, was one of the greatest icons and a fierce warrior in the fight against global health inequity, to the extent that in Rwanda, as you saw in some of the pictures, or in Haiti, in Rwanda specifically, he was critical in establishing a whole university that dealt with global health equity or inequity. I invite you to read the bottom part of that email exchange that led to the creation of the University of Global Health Equity in Rwanda. And Paul was responding to Bill Collins from the Collins Foundation, and he said, what a great vision, and one that squares with the Rwanda vision for pulling people up by building a knowledge economy while delivering care, and what better way to promote peace, justice, and development in the region. That's an email response from Paul to Bill Collins, and that started, or the basis for the creation of a whole university devoted to addressing inequities in global health. So, as I said earlier, my last conversation with Paul was around HIV/AIDS. And HIV/AIDS, 20 years ago, symbolizes what you think of when you think of global health inequity, is truth in your face. This curve shows you where we were 20 years ago and the progress that we've made so far. And the blue line shows you where HIV was trending, or the people living with HIV/AIDS and receiving treatment and dying from HIV/AIDS. The blue line is the United States, and the red line, Africa. And where you see a sharp drop in the blue line is when treatment for HIV/AIDS became available, and you saw a dramatic decrease in the number of people dying from HIV/AIDS. But at the same time, you saw that because of lack of access to treatment in Africa, the numbers continued to increase significantly. And between 1999 and close to 2000, about 11 to 11 million people died in Africa while waiting for access to treatment. Those are the things that fueled the fighting spirit in Paul's mind to continue to engage global health community to address that issue. HIV/AIDS was devastating. You saw that before PEPFAR, Global Fund, and others, life expectancies in many countries in Africa had decreased significantly. About 35 years in Zimbabwe, about 28 years in Botswana, about 12 years in South Africa. And very importantly, it was not just a health issue, it was a developmental issue. GDPs had decreased by 2.6% over the period of that time. Very, very critical. All hands on deck to addressing that. Even President Mandela, I remember in 2000, we were all in the streets of Durban, marching to protest and ask for being all of us activists. You took up your coat as a scientist or a medical doctor or a politician, and you were on the street advocating for access to care. So PEPFAR, I have described truly, first of all, a privilege to be running that program, the greatest program that any nation has ever put out there to supporting a single disease there. I'll call it the greatest act of humanity in the fight against infectious diseases that we have ever known in the history of the world. And how did that happen? That is all due to political leadership. I've always argued that good political leadership plus good public health practice saves lives. And that is the act that President Bush exercised in the State of the Union address. And I call it the greatest inequality equalizer. I've argued in the previous slides that without PEPFAR, you continue to have seen that whole countries were nearing extinction. And I'll show you a quotation from the president of Botswana. I'd like you to look at the second part of this slide, where President Bush says, seldom has history offered a great opportunity to do so much to so many. Seldom has history offered an opportunity to do so much to so many. And I'm not even sure that President Bush at that time knew what the impact was going to be for PEPFAR on his act. I'd like you to also watch that picture below carefully, where it symbolizes good politics. President Bush is there. The then Senator Biden was there with President Biden today, and look at how harmonious. And just behind President Bush is former Secretary of State Kerry. All came together, brought their minds together to solve humanity's greatest challenge at that time. What is the impact of that act? When I say good global health politics plus good public health leads to life saved, that is what it means. Over the years, the last 21 years, PEPFAR has led to a decrease in about 68% rates of deaths. New infections have decreased by 42% in high-burden areas. About 25 million lives have been saved. 25 million lives have been saved. 5.5 million children born free of HIV/AIDS, thanks to that program. And beyond that, as I said, HIV was not just a health issue, it was a security threat, it was a health threat, and also a developmental threat. So look at this slide carefully. Look at the GDP. I showed earlier a slide where before PEPFAR, GDP had decreased about 2.6 percentage points, but look at what it had done now in those countries that have benefited from PEPFAR because the workforce was completely disseminated. 2.1% GDP capita increase in countries that PEPFAR has supported. About 9% girls and boys who have stayed in school rather than drop out. Child mortality had decreased about 35% in countries that PEPFAR had intervened, not just in saving children's lives, but overall child mortality. And immunization rates have increased about 10 percentage points in those countries. This graph shows you the trajectory where if you look at countries like Botswana, Eswatini, Namibia, how the blue line shows you the rate of new infections, how they've decreased steadily over the years, and the red line shows you the rates of mortality. And where the two lines cross is where you really want to be. You want to make sure that the rates of new infections come down significantly, and you help you control the epidemic. We continue to see that not just in Africa, but in Cambodia, in Nepal, in Thailand. We are very encouraged to see that those investments, which are even outside of Africa, are continuing to yield those fruits. This is what I promised you. I said this is published a commentary from President Festus Mogae, who is one of the great political leaders, president of Botswana at that time, former president. And he said this, he said, how PEPFAR helped to save Botswana from extinction. How powerful that can be. How powerful that can be, where PEPFAR saving the extinction of a whole country. And in red, he went to the United Nations and he made a plea. He said, like a war, HIV was taking the cream of society in terms of youth and health, says the president. And that united his fight. Those are the fights that Paul Farmer fought throughout his life. But however, we continue to see inequality gaps. In some countries, Burma, Indonesia, and Laos, we are not seeing that decrease in the rate of incidence enough as we are seeing in high-burden countries where PEPFAR is intervening. And worse still, in some countries, like the Czech Republic, Turkestan, Papua New Guinea, Philippines, we even seen increases in the rates of new infections. So HIV is not over. HIV is not over. It's still a serious threat out there, a serious security threat, a serious developmental threat. The rates of new infections have actually increased by over 200 to 300% in Philippines in a very short period of time. But again, on a positive note, I'd like you to look at this graph. Let's go back to Africa, the high burden areas, and look at where we were just in 2012. The red color there shows you the access to treatment. And the greener the color, the more that country has received treatment there. So you clearly see a gradient from left to right, where even in 2012, where PEPFAR started, the rate of coverage for people receiving, who are infected, receiving treatment was still very, very low, because it was an uphill task to administer treatment into populations that had no infrastructure for that. But see where we are in 2022. And we're greening that. The goal is to be able to green that continent as much as possible. Not just green it, but dark green, which means making sure that many countries achieve what we call the 395. 95% of people that are infected know their status. 95% of those who know their status are on treatment, and 95% maintain viral load suppression. And that is what is going to give us that curve. The curve with the blue line, which is incidence that decreases below the level of people who are dying of HIV/AIDS. So going forward, we recognize in PEPFAR that HIV is not longer an emergency response. We need to have a sustained response. A sustained response because it's not over, but the crisis that we had 20 years ago, where you move into a hospital in Haiti, or in Uganda, in Botswana, and you see many patients lying in clinics on hospital beds, is over. I think we can proudly say we won that battle, but we still have to preserve the peace, which is to sustain the people living with HIV/AIDS and design programs accordingly. So we in PEPFAR are prioritizing three things. One is to sustain the gains that we've had, the 20+ million people that we have on treatment, but accelerate. I showed you evidence that in some countries, you still have the rates of new infections that are increasing. But then thirdly is to develop a sustainability plan. Where do we go from here? How do we get to 2030? And how do we go from 2030 beyond? The response to HIV/AIDS is caught up between what I call the malaria response. If you recall, in 1955, WHO launched the malaria response eradication program. And by 1970, when they stopped the program, but we saw a re-emergence of malaria. The gains that were made over those periods were completely eradicated. On the one side, we saw what happened with smallpox eradication. With consistent engagement and political leadership, we, the collective we, were able to eradicate smallpox. So HIV response is caught up between there. Either we stay focused and finish the fight against HIV, or we relent and we get the malaria effect. That's the problem, the big question and challenge in front of all of us. So PEPFAR has developed a strategy and published that with President Biden just 2 years ago, where we said we have to have 5 priority areas, which is addressing the inequity gaps in the priority populations, key populations, children, adolescent girls, and young women, as well as those men who rotate in and out of care. But also look at the sustained response, strengthen public health systems, including laboratory medicine. Right? That is why this is so important, this meeting. But look at transformative partnerships, which I'll come back to that, and then follow the science. But to do that, we need 3 enablers, which is community leadership. Community leadership, not just community engagement, but leadership. Put the resources in the hands of the community, let them find solutions for their community, innovations, and leading with data. So what are the lessons we've learned, in my view, from the response to HIV/AIDS globally? There are 3 main lessons if we have to close the inequity gaps in global health. One is political leadership. Without the bold, courageous leadership from President Bush and the Congress at that time, uniting and rallying behind a common cause, we will still be struggling with the global response to HIV/AIDS. And I'll come back to that shortly. innovation and data-driven approaches, and transformation partnerships. So let me unpack each of those. Unfortunately, today, the challenges that we face in global health are not decreasing, they are increasing. I call it the syndemics in global health, where you have the emerging and re-emerging infections, the endemic diseases, i.e. the TBs, the malaria, the tuberculosis, and the non-communicable diseases. When Blair and I and others when I was at the CDC, US CDC, and we're fighting HIV/AIDS, we just had no idea about COVID, that COVID was going to hit us in a way that, and when COVID hit for so many years, about 3 years, the impact on HIV response was severe, and TB and malaria response. So we begin to see that for close to 25 years, the HIV response defined global health. But as we move forward, the emerging infections are beginning to push those gains that we had on HIV seriously. And of course, we have to stay focused, and we have to be able to address all those three pockets together. To do that, we have to recognize that, again, non-communicable diseases are on the rise. This slide shows you a study that was analyzed and published in The Lancet about the global burden of hypertension. And clearly, I want you to focus on the red bars. The red bars are people that are undiagnosed on hypertension. And even if they are diagnosed, the people that are actually receiving treatment, are few. So if you look at the green, that is the success story there. So it's very, very limited. And hypertension-related deaths account for about 10 million deaths a year. And those are still challenges that we face. So political leadership, as I said, Peter Piot published a book. Peter Piot, the former director of the London School and the former executive director of UNAIDS, and he said in that book, science does little good when it operates independently of politics and economics. And politics is worthless if it rejects scientific evidence and respect for human rights. I think Peter was absolutely right at that time. Without good politics, blending with good science and good public health practice, we go nowhere in solving those problems. The early 2000s were remarkable, where for the first time, the UN Security Council adopted Resolution 1308. It was the first resolution ever to identify AIDS as a threat for global security. And in 2001, the UN General Assembly held a special session on HIV/AIDS. And the heads of states in Africa also had a meeting in April. That's where the political push originated and drove the global response to HIV/AIDS. So I've shared this slide and bring this up to say that if we have to be successful in addressing the syndemics, we have to make sure that we engage the political leadership on every way. And at the heart of COVID, the UN, ahead of COVID, that about 20 million lives were lost due to COVID, directly or indirectly. The UN General Assembly or Security Council did not come together to issue a declaration on that. So HIV/AIDS in early 2000 was so important, critical. We have to ask ourselves the question, what is it that led us in galvanizing the political spectrum to align and issue such important declarations? This is an example of the White House ceremony that led to the creation of the Global Fund with Secretary General Kofi Annan, President Bush, Colin Powell, and others all coming together to recognize that HIV/AIDS was a serious security threat and developmental threat. Data and innovation. Again, this is another area that Paul led with passion. He talked about, together with Victor Zhao, talked about the importance for an opportunity to align technology innovation with the idea of equitable benefits across society. Because technology by itself, if it doesn't get to the end user and address inequality gaps there, is meaningless in global health. I think that we saw that with COVID vaccines, where we had vaccines on one side, but access to vaccines was challenging, and even in the uptake there. Innovation in HIV continues to be exciting, which as we speak today, we are dealing with an exciting development, the development of long-acting injectable that Gilead just produced, where hopefully, once it gets to the community, it can have 2 injections a year, and that can have been proven to be very, very effective in preventing the rates of new infections. Artificial intelligence. I think this is a technology that is already playing a critical role in developing countries, but we have to be very, very intentional in pushing this technology through to where it benefits the community and reduce the inequalities there. To do that, there are 5 ways that we must democratize AIs in healthcare in low and medium income countries. Data culture has to be improved, regulatory issues and standards, adopting local solutions, and I'll come on, my next slide will speak to that, funding and infrastructure. We also have to look at the new ways that we can deploy, especially in like gene editing technologies, to modify the way that we deal with malaria, the control of malaria, because it's a challenging, it's a tenacious disease. Malaria was identified in 1880, and the first malaria control programs were established in West Africa in 1902, but today we're still dealing with serious malaria burden. I mean, I was in Nigeria just last year, went to a hospital in Kano with Minister Pate, and saw a ward that was full of children grasping with their last breath because of malaria infection. But that is a program that we've lived with since 1902, where the first malaria control program. So innovation must be applied in addressing the inequity gaps. Lastly, let me just conclude by reflecting on transformative partnerships and speak to a disease that we all have worked on, the ASCP, working on cancer. I think one of the pictures that you saw was when Blair, myself, and Paul were at the White House, and I remember vividly and seeing Paul sitting at that far side in the meeting room and saying that success has many parents, but in failure you are an orphan. And I left that meeting looking at him like, that is so wisely stated. And we're discussing cancer treatment or prevention programs across the world. And this slide shows you the burden of cervical cancer. The red in some shows you where the greatest burden is. And the greatest burden, unfortunately, overlays with the burden of HIV/AIDS, especially in Africa and some parts of Latin America. So the spirit of transformative partnership, we at PEPFAR have established over the years a partnership called Go Further with the Bush Institute, where essentially we look at, we acknowledge that there are 11 million women who are living with HIV, and in countries that, why is this moving forward so quickly? Let me go back just. Okay, yeah. And that because of that program, about 7.4 million screenings have been performed, and about 79% overall treatment in those countries in the Go Further initiative. And we recognize that women with HIV are 6 times more likely to develop cervical cancer. And this is truly a partnership that brings together the private sector, the Bush Institute, and others again. That's the kind of partnerships that will be required in solving some of the challenging global health issues that we're dealing with. But very importantly, I mentioned artificial intelligence. Using artificial intelligence technology, okay, and applying that and adapting that, customizing that in resource-limited setting is going to be key. And this is a publication that I found that clearly shows the accuracy and efficiency of deep learning-based automation for dual staining cytology in cervical cancer screening. If you look at the media there, look at the high percentage of accuracy of what this technology can do. The question is, how do you make that available in developing countries? This gentleman leads what you call the data pathology, which combine artificial intelligence and digital technology to combat cervical cancer. He's from Morocco. I mean, I highlight this because it shows that these technologies can actually be developed in developing countries. We have to develop the right partnerships to do that. So what is he essentially doing? The mission is simple: to address the lack of or delays in cancer diagnosis, particularly in medically underserved countries, using innovation. What they essentially do is to conduct biopsy at the patient's bedside, prepare the tissue samples, digitize it securely, and anonymously transfer that through the web platform to a site that can actually interpret that and send back the results, but thereby increasing the possibility for early and quick diagnostics. That's the kind of innovation that we have to harness to address some of the inequities and gaps that exist there. Now, let me conclude on this. I think I'm always wondering, what would Paul be saying? PEPFAR has been reauthorized, as some of you, all of you know, just for the last year it was reauthorized for 1 year, which means the reauthorization will end by the end of March next year in 2005. Elections matter. But I'm very encouraged that PEPFAR has always been a bipartisan program. It started under the Bush administration and has always been supported by all administrations and Congresses. But if Paul was here today, I can imagine Paul standing up there, raising his hand and saying he needs to reauthorize PEPFAR clean for the next 5 years so that we can finish the fight against HIV/AIDS. That is the call to action that all of us should be saying to looking back at the results and saying, we don't want to go back to the scenario of the malaria elimination, where we take our eyes off the ball and the gains we've made all are eradicated. We want to be in the smallpox lane where we stay focused, finish the fight, exercise that leadership that the U.S. has known over the years, and bring HIV/AIDS to an end as a public health threat by the year 2030. In doing that, we have to recognize the financial challenges that the whole world is facing, but very importantly, resource-limited settings, that the relationship between the donor and domestic financing needs to continuously to be enhanced. It's not a question of PEPFAR parking or Global Fund parking and going, but it's rather building that sustained partnership between the countries that benefit from, so that we address the inequalities and inequities, and recognizing that a threat everywhere in the world is a threat everywhere in the world. We find ourselves at the crossroad where we either go somewhere with global health inequities, we go nowhere, or we go anywhere. So thank you so much for the opportunity to speak with you today.
Ladies and gentlemen, please welcome to the stage the ASCP Chief Medical Officer, Dr. Ali Brown.
Thank you. Yeah. Okay.
Well, thank you so much, Ambassador, for sharing all of that with us and helping us understand how really small our world is and how much there is going on and how much we can help with healthcare across our globe. I have some questions for the ambassador today, so we're going to talk a little bit. I kind of want to start with, the people out here in the audience that are working in our laboratories. We're facing lots of challenges, workforce, financial challenges, et cetera. And so sometimes it's hard for us to think even outside of our own sphere, just because we have so many issues going on locally. But as we know, there is a huge global need as well. So what do you say to those people? Why should we all be engaged in healthcare on a global scale?
Yeah. No, thank you. Global health is global, and health is global. We saw what COVID did to all of us. When COVID emerged in a place that I've never heard before, Wuhan, and where some people, and including the people that used to work for me at the Africa CDC, said, Director, why are you activating an emergency center, an emergency response to COVID, which is happening somewhere in Wuhan, which I had to Google to find out where Wuhan was. I've never heard about that. But within 2 months, COVID was in 165 countries. 2 months, 165 countries. COVID taught us 3 things: that we are more interconnected than we thought we were, that the vulnerabilities that we knew that whether you are in the global north or global south, that we are equally vulnerable. Who could have imagined that a virus will emerge in China and within a few months or days or weeks show up in the US and lead to the deaths of 1 million people, over 1 million Americans? I never thought of that. I was leading the response to COVID on the continent of Africa, a continent of 1.4 billion people. And I thought, boy, this is where the epicenter is going to be. Millions of lives are going to be lost here. But it just shows us the common vulnerability. But lastly, the third lesson is the inequalities or inequities that exist, that COVID didn't bring inequities, but it exposed the inequities that exist there. And it shows us that a threat anywhere in the world is a threat everywhere in the world. So I think the leadership that the United States has exercised over the years in global health is not just protecting others, but it's protecting ourselves. The platforms that PEPFAR has put in place, and I didn't have time to go into that, and Blair and others, we've worked together for many years to build those platforms, are today being used in responding to Mpox. Okay, another threat that has been around for a while and not paid attention to, but today those platforms are coming handy. The platforms were there to support the COVID vaccination in the continent of Africa and outside of Africa. The platforms were there to roll out diagnostics there. So again, by preventing these diseases from happening anywhere in the world, we are very directly preventing them from affecting us.
So, you know, another issue that we both feel, both in Africa and the US and beyond, is our issue with our workforce within the laboratory, really within every industry. But of course, here we're talking a lot about the laboratory and with pathologists as well. So, you know, a lot of what we've done, but ASCP has done in collaboration with PEPFAR, is to scale up workforce for HIV, AIDS, and other communicable diseases. Did that help with the COVID response in Africa, just having that infrastructure in place?
It did. I think, first of all, let me just recognize the tremendous contribution that ASCP did over the years in developing quality workforce, and I underline and bold quality workforce because that is so central. And we developed, when I was at the USCDC, developed joint programs and strengthening the certification of workforce on the continent. I highlight that because quality is key. 60 to 70% of how successful we are in managing patients depends on the diagnostics. And unfortunately so, is that I'm a virologist, so I speak from personal experience, is that laboratory medicine experts are unsung heroes. They're the people that you don't see. I don't think a patient comes into a clinic and see a lab person. I mean, they see a nurse and they see a doctor. Okay, so they go home praising and recognizing that doctor and the nurse, but the people behind that, the unsung heroes, are the doctors. And for many years, as you know, I have been a very strong advocate for strengthening lab workforce. Actually, I created the African Society for Lab Medicine with partnership and support from ASCP because I was very passionate to elevate that visibility of lab workforce and the quality and the quantity of that. Having said that, I think we have to continue to be resilient, the lab workforce, recognizing the importance of what we do, but promoting what lab medicine does is so important to do that. We also, together with ASCP, established a journal with the African continent called the Journal of African Journal of Lab Medicine. We're very clear it's a lab medicine, not laboratory. So I think there will continue to be shortage of lab workforce, not just lab workforce, but human resources for health as a whole.
Yeah.
It's a critical shortage across the board. We saw that during COVID, not just in developing countries, but here in the United States. We've seen that in Europe as well. So it's something that we have to collectively, as a world, recognize that we'll never solve those syndemics, the three pockets of challenges that I indicated, without a very strong workforce, regardless of whether you're dealing with lab or nurses or doctors.
And you really don't think about how the most basic way to think about a workforce is to actually have a population that can work. And if you have such turmoil and such high burdens of disease, it's your workforce is decimated from the start. You can't even accumulate one.
Absolutely. And we saw that with COVID, the number of nurses and healthcare workers that took the hit. Okay, they are the frontline care providers, and it's very easy to see where you have a new threat, a disease threat, and stay home, work remotely on front. But how does a nurse, a doctor, or a lab person work remotely? They have to be there at the front line. That's why the numbers of casualties when you have a new infection. And we must protect the people who protect us. That is the frontline workers.
Absolutely. So the good news is we have so many members and volunteers who want to help on the global front. We have people ask us all the time about opportunities, and we do have multiple opportunities for them to help. But a lot of times people think about an opportunity is to travel, to go to sub-Saharan Africa and to be there to help out. And that's great, to be able to do that. But what are some other ways that our members and our volunteers, our lab workforce, our pathologists can help?
I think there are a couple of, we have to think of that in a triangle of what are the services that are required, what are the systems that will be required to deliver those services, and what are the institutions that are required. So if you take a member, an ASCP member who is interested in supporting the legacy of Paul in Rwanda, you need an institutional backing of that individual to go do that work, right? So that, what does that mean? To care for you, protect you, not looking for luxury, but who organizes your travel? Who is accountable for your safety when you are in the field in Rwanda or Haiti and stuff? Then what are the systems that you are going to work in there? I think we have to look at this from end to end as we develop those programs there. So that is one. That is related to being on the spot and engaging in the communities where they need you. The second component is doing things remotely, right? Like I showed there the gentleman in Morocco who has developed the AI technique where you capture, you take the specimens at the bedside, you manipulate with that, but then zoom them over so you can say, well, is there a clinic, a hospital here that has such a program that is designed to facilitate those images coming from a distant country and in a very timely fashion give the results back? I mean, some of those cytology results take for months before they know their results in developing countries, months, and at times years. You go into a country, you see those slides are all lined up, they're waiting to be read because there's no pathologist to read that. So there are all kinds of creative ways that we can, but it needs to be more, it needs to be organized. It needs to provide an institutional backing to it. It just can't be a random process.
Yeah, and I'm proud to say that ASCP participates in our Partners in Diagnosis program where we're doing digital pathology, and we have multiple sites within sub-Saharan Africa and in Haiti where we are facilitating those types of diagnoses. And for our pathologists in the audience, we definitely have opportunities to volunteer to do those things. So Ken Landgraf is our executive director of our Center for Global Health, and seek him out at the meeting, and he will tell you how you can do it.
Yeah,
so we're working on that.
That's very important work, very important work.
Absolutely. You talked about collaboration, having support from your organization in order to do this meaningful work. How about collaboration with not just institutions where people are working, but with international health organizations and things like that? You talk about how people have to work together, there has to be leadership, et cetera. How does one go about making those connections and bringing everything together to really hit that point where it's all working?
I think there are two levels in global health partnership, actually 3 levels that I have always thought of. I mean, and it's just my reflection doing this for over 35 years, is the global health institutions, I mean, coming together and coordinating the efforts, i.e. the WHO, the UNICEF of the world, the UNAIDS, I mean, and saying, what is the problem we want to solve? And what are the right partnerships, UNICEF? I think if you have been tracking the literature, that conversation is beginning to happen now. They call it the Future of Global Health Initiatives, where the big players and donors all come together to avoid silos of efforts, but also focus on the issue that might be solved. So that is one. Second is at the country level. I mean, what do we do? I mean, and it's not uncommon for when you go, the volunteers or ASCP staff go to country X, and the chair you are sitting there 2 hours ago, another partner was sitting there and telling the minister and the government of that country these wonderful things that they can do for you, wonderful tools that they have. And that government or partner country is sitting there very confused, very confused as to what am I hearing here about. So coordination in country is so important. Thirdly is leveraging the private sector. I think, yes, public health is for the public and it's a government-owned space, but we have to be creative to begin to bring the private sector into the fold. Some of the things that enabled me when I led the COVID response on the continent of Africa was a strong partnership with the private sector, the banks, and the private sector as private sector. The development of tools like a platform that we created in the middle of the crisis to pool commodities so that a country in Africa can go in there, like Amazon.com, you click in, and then you pull down things that you need, put it in the basket, and you pay it, and it will be delivered to your country.
Free shipping?
Shipping was paid off.
I only buy stuff with free shipping.
Yeah, you paid, it was embedded in the cost of that. I think AMSP.Africa, if you pull out your phone, cool. you do AMSP.Africa, that website will pop up. And each country was given a code. And so when you go in there, you put in their code and whatever. It was done by the private sector. So we know what...
We need that here.
Yeah.
I mean, that's fantastic.
You know what to do, like in public health experts or global health experts, but you don't know how to do it.
Yeah.
When we sit down with the private sector, this is what they do for them. So we have to really explore that angle and say, what more can we do with the private sector? Not just asking for money from them, but saying, look, what can you do? Can you develop some tools for us? These are the tools that we need. So, yes.
Yeah, you bring up a good point about not just donating money and things like that. You know, what is the measure of success? It's not how many dollars can be raised. So how do you measure success? How do you define success? What can we look at to diagnose success in our programs?
Yeah, the impact of what we're doing.
Exactly.
Unfortunately, it takes, there's what you call, or what I call pandemic memory loss, where at the heart of a pandemic, if you say, well, let's sign a treaty today about collaboration, coordination, everybody signs it. But months after, once that threat is gone, you bring that same treaty, everybody looks for a word that doesn't right, it's not right, and it's all reasons why we shouldn't work together. So I think we are struggling with the Pandemic Accord in Geneva, which wasn't signed during the last World Health Assembly, and we still, as State Department, we are continuing to work on that. But I always joke that if you had established that Pandemic Accord in 2021, everybody would have signed it. Okay, okay. It was, I remember convening a meeting and bringing together all thought leaders to think about access to vaccines and vaccine manufacturing in Africa. That was April 21 and April 22, 2021. 40,000 people were on the platform in 2 days. 40,000 people. It was the greatest Zoom call because everybody wanted to do something there. Mm-hmm. Today, if I call such a meeting, I would be very lucky to have 100 people who come in to talk about vaccines there. So that's the memory loss, very, very easily. Then you have Mpox, then everybody wakes up again, oh, WHO has declared an emergency of international concern. Let's do something. And then we forget about it.
Pandemic memory loss. I think you can fill in the blank memory loss. I'm going to use that when I get home with my husband when I talk about something. Anyway. So how can we better support training? One thing I think about, ASCP, one of the 3 pillars of our organization is education. We're very passionate about education. We have so many educational offerings, and the vast majority of our educational offerings are online. So these resources are available no matter where you live in this world, perhaps in the universe. So how can we better prepare and train pathologists and laboratory professionals around the globe?
I think building regional platforms could be a way. I mean, I would not, I don't think I know the answers to that, but if I were approaching this, I'll look at regional platforms, but platforms that can also empower and certify them, okay, so that it's recognized. So it starts with recognition. What is that training that I am going to receive in Haiti or in Ukraine or in Kenya, and how is that going to help me to be here? The beauty is that when you are certified and they know that, it's recognized, and but we have to ask ourselves the question: if I'm doing that in country X, how would that be recognized, and how would that reward my career to go up the ladder? So I think those are all elements that we need to think through. Yeah, but the content itself for individuals is so important. I've seen some of those contents, and they are very rewarding.
Excellent. You hear that back there, Dr. Holliday? We need more international BOC certification. So the charge has been laid. In that same vein, assuring that there is appropriate quality within laboratories. We understand from our work in sub-Saharan Africa that not all labs have the resources to do, ISO accreditation, et cetera. And it's kind of an all or nothing. How is there a way that, and we've seen these things with work with HIV/AIDS, are there ways that you've seen work that really promote quality in the laboratory, but on an affordable and attainable scale?
Absolutely. I think the partnership that we had developed at that time with ASCP and others, APHR and ASM, was very powerful and transformative. And I don't think enough credit is given to that work. When we started, and we were in Kigali in 2008 or 2009, and to launch a stepwise process towards accreditation. The first thing that you are faced with is that the opposition from the status quo. And we heard statements like, "You're dreaming. You will never be able to accredit labs on the continent of Africa." At that time, there were just about 40 labs that were accredited, and mainly partner supported. Excuse me. So we did establish a program called Stepwise Process Towards Accreditation, and today more than 1,600 labs are accredited in Africa. I think that's so it can be done. You have to have the right leadership, the right partnerships, and that was only done because CLSI, ASCP, ASM, they all rallied behind me, and they were, as any change, when you lead any change, forces that were not for that approach, and we were tenacious, we remained focused on it, and we said we're going to lead and change with evidence and data. And years later, we started showing that labs were truly accredited, and accrediting bodies like Kenya and others were developing their own national accrediting institutions. So it can be done.
Rising tide. Yeah. And working all together, stronger together. Yeah.
Exactly. It means stronger together.
Yeah, we believe that. It's real. So we just have a little bit of time left. What is the message that you'd like to give we have a lot of medical students here today, laboratory students, residents, our future. What is the message that you want to give to these people about how to get involved and how to make the planet better from a global health scale?
So first of all, my message is laboratory medicine matters. And even though you are on Unsung Heroes, I say this as a virologist, a bench virologist. I started off as a molecular virologist and move on and move into public health, and now I don't know what I am anymore. So
join the club.
I do something. But it matters. But I think the second thing is to be passionate with what we do and never lose focus on the fact that, as I said earlier, 60 to 70% of our own treatment outcomes and success depends on what we do quietly behind the scene. Has some of the best innovations there. Where would we be today in the management of HIV/AIDS without knowing that you have HIV, which is ability to diagnose accurately using that simple rapid test or analyzer? Where would you be today without having that measure of viral load suppression there, just to use HIV because I talked on HIV there, and many others. So I think being proud of that profession and promoting it and encouraging others to see that as truly a career that you can be proud of, at the same footing as saying, look, I'm a proud nurse, I'm a proud pharmacist, I'm a proud clinician, there is what we all have to do and continue to do that.
Absolutely. Well, thank you for that. That's amazing. And not just because you just buttered us up because you love the lab. We have a surprise for you today. Ambassador, it really has been such a pleasure. And because of all of the phenomenal work that you've done addressing global health, we are very honored to award you with the 2024 ASCP Patient Advocate Award. So, everybody. Come on over here.
Thank you, thank you, thank you.
It's so honored to have you here. Such an honor for me to be given this pleasure.
Thank you.
Awesome. Yeah. I think you're supposed to take a picture. Thank you. Okay. Thank you guys so much.
Yeah.